Good evening, all. Women's health is very important for the family as well as the society. So, we are here today to discuss her health at a very crucial section of life, that is menopause. It is not the beginning of the end. On the behalf of AVOGS, I welcome you all to this pertinent topic on the management and updates of menopause. At the outset, I would like to invite Dr. Krishna Shishi sir, past Secretary of AVOGS, to invite Dr. Sundari Madam, today's moderator for panel discussion. I also invite Dr. Rajni Madam. Madam is a private practitioner at Prakamsh Rai Hospital, Anantapur. Madam is interested in menopause. Thank you, madam. Welcome you. Over to you, sir. Mr. Shishi, sir.
Thank you, madam. I'm happy to introduce our senior professor, Dr. Sundari madam, who is native of Anantapur. She studied at SSBN College and studied at Kannur Medical College. Madam retired as professor at MS Ramaya Medical College. Madam teaches excellently and giving bright future to so many budding gynecologists. We welcome you, madam, and we are eager to hear you. And other thing is, most of the time, it is the day for preserve uterus. Previously, it was save uterus. Now it is the day for preserve uterus. For simple complaints like white discharge and bleeding, just most of the women adopted to remove their uterus. Now it is our duty to preserve uterus. So, madam, moreover, menopause gives lot of problems, and we expect a beautiful solution from you, madam. Over to here, madam. Over to you, madam.
Thank you, sir, for your kind words. At the outset, I would like to really thank Vinutana and the Nagajyoti who are instrumental for making me to be a part of your webinar today. And of course, I thank Shield for arranging this. Without much ado, I think we have 40 minutes of time. There are experts are there as a panelist for me. Young, enthusiastic experts are all there. And they will do the job. Dr. Vinutana, Dr. Nagajyoti, Dr. Harshita from the Medical College, Government Medical College, Anantapur. Sirisha, my dear student and my colleague now, proudly I say, she is from Batalapalli. And Dr. Sweta.
Good evening.
Yeah, I think, hi Sirisha. So all of you will be
Hi,
doing
good
my
evening.
job is only to ask a questions. Shall we start, all of you? Sweta is there?
Shweta is not yet joined, madam.
Not yet.
Probably she may join.
Okay.
She is not taking call also.
Okay.
Probably she may join in the middle. We'll start, madam.
Okay, okay. See, menopause, as you said, it's a very vast subject, but all these years, menopause was not being taken as seriously. But now the lifespan of women is increasing. Half of our, at least 1/4 of our life, we are spending as menopause because of the lifespan. So we need to know what are the problems we have for this menopause woman and what are the solutions we have. There are various things which we cannot be fitting into one webinar like this. Probably today we will take up one aspect of menopause. First thing, let us know there are a lot of terms are used for menopause. What exactly we mean by these terms we'll know. And one of the very commonest symptom women really suffer from is the vasomotor problems. See, this vasomotor symptoms, we are going to address that symptom alone today for the next 40 minutes, what the time we have. So I'm sure that all my panelists would do wonderful job. Thank you, all of you. Okay. 42-year-old Mrs. P complains of irritability, anxiety, and loss of concentration for the last few months, and her cycles are slightly irregular now. And then LMP is 1 month back, and she is otherwise healthy. She wants to know whether these symptoms indicate she's an educated lady. She reads a lot. So she thought, my God, am I going in for menopause? She was thinking because she's only 42 years. Now, before we answer her question, let's straighten our idea about this and let us know what exactly we mean. She wants to know whether she is menopause. Now, there are a lot of terminologies we are using. The menopause, menopause transition, post-menopause, early menopause, delayed menopause, premature menopause. I think all of us are getting confused. Now, to straighten this and give us a clear idea of what these terminology mean, I'll invite Sirisha, the youngest of the lot, to start with. Sirisha?
Yes, ma'am.
Yes, please. We'll start with you. Can you give us all this terminology? It is confusing for us. Sirisha, can you straighten it and tell us clearly what is what?
Yes, madam.
Please.
Madam, menopause. Yes, madam. Menopause is the period where cessation of the menstruation due to loss of ovarian function, madam. It's a
Okay.
retrospective diagnosis, madam.
Okay.
So in this, we have early menopause and perimenopause, delayed menopause, and delayed menopause, madam. And we have another word, menstrual transition also, ma'am.
Mm-hmm.
Early menopause is within 1 year of cessation of the menstruation, madam. Delayed menopause is 1 year after the menopause, madam.
No, that is the stages of menopause, Sirisha. Now, early
Yes, ma'am.
menopause, see, the early and late menopause or premature menopause comes with the age of the person. Is it not?
Yes, madam.
Below 40
Yes, ma'am.
years, if she has stopped, her ovarian function stops before 40 years, we call it as premature ovarian insufficiency. We used to call it as premature
Yes,
ovarian
ma'am.
failure. Now we call it as premature ovarian insufficiency. Very, very important aspect we need to know, all of us. We need to diagnose because the diagnosis will be delayed for 2 to 3 years, unfortunately, in them. Now, delayed menopause, early menopause is 45, before 45 years. After 40 and before 45 years, if she goes into cessation of ovarian function, we call her as having an early menopause. Now, as against that, late menopause is either it is 2 standard deviation above the normal range for the country, because our country, the menopausal age is 46 plus 5 years, 46.5 years. But Western countries is 54 years. On the whole, if you take it as 54 years, anybody who has not menopaused up to 54 years is called menopause. What you have said is this. Okay, Sirisha.
Yes.
This
Yes,
is,
ma'am.
this is the stages of straw staging. It is done international conference in July 2001. Straw, it was the staging of the reproductive aging workshop was in that what you said, menopause transition in the early and late, that is -2 and minus. That means before they become completely menopause, 2 years before, that is called early menopausal transition. And late is just 1 year before attaining menopause is late. And after menopause, 1 year is early. And after 2 years late. And after that, lifelong, it is permanent menopause, very late menopause. What is menopause transition and pre-menopause or menopause transition? Perimenopause or menopause transition is the same period where the ovarian function starts coming down. How do we know ovarian function starts coming down? If you do in them, she asked, this lady is 42 years, she wants to know whether she is menopausal, but she has periods. She doesn't completely stop her menstruation. When you take the definition of menopause, it has to be cessation of menstruation for 1 year continuously. But she is having periods, but she has got some symptoms. So she comes under what category now? This lady comes
Perimenopausal.
Perimenopause, menopausal transition.
very nice. So she comes into perimenopause, menopause or perimenopause. Which one she comes into? She comes into
Perimenopause.
perimenopause or
Menopause
the
transition.
Menopausal transition.
and she comes into menopausal transition. I think we are clear about this thing. So this lady is menopausal transition, but she has got a lot of symptoms. She is having a quality of life is going down. Now, these are all the various symptoms of what we could have in them. This lady has got this mood swinging, low mood, anxious, irritability, exactly. These are the symptoms she has got. So this and also hot flushes can start in the perimenopause or menopause transition time. These things can cause, is it not? So she is in, for us, before we answer to her question, we know that she is in perimenopause. So she's in perimenopause. How do we have to manage her? Okay, Harshita.
Yes, ma'am.
Yeah, how will you manage her? What investigations you would like to do? And or you don't want to do any investigation, or how do you manage her? She has come to you for some help. Yes, ma'am.
Yes, ma'am. Ma'am, she is having irregular, despite her symptoms of irritability, nervousness, and even irregular periods, there are certain investigations we have to, it is not to diagnose whether she's going into menopause. Yes, we have to do certain investigations to determine, you have to rule out other causes of these nervousness or irritability also, ma'am. So I would suggest that we do a serum thyroid profile
Yes.
and other blood sugar levels and lipid profile, a complete blood count.
Mhm.
I think these are the basic investigations to be done, ma'am.
Should we do FSH level?
I don't know, ma'am, because here it can. One thing is that there is fluctuation in the FSH levels because of there are irregular periods. So there would be a fluctuation of FSH levels, and it would not be diagnostic at a go because even if we would want to diagnose menopause now, if we even if we say FSH levels, it would not be just a single FSH level more than 40. It should be at least two FSH readings, at
Yeah.
least about 6 weeks difference, more than 40.
Yeah.
But she's still having her periods even though irregular.
Very
So I
good.
think we should not go
Yeah,
directly
very
for FSH.
may not be still she's having periods, so we don't label her as menopause, but
Menopause.
we have to counsel her and say that you must be going in for menopause. If she says definitely should I know, here when you do FSH, probably FSH may be high
Yeah.
because it fluctuates, or sometimes it may be normal also.
Mm.
So we just cannot say that. But yes, if she is very firm that she wants to know. So you can, if you want, see, one thing is to diagnose menopause, never do FSH. It is not necessary to diagnose. But here it is transition period to know, as you rightly said, other things we have to rule out. And then probably if she is in a transition, FSH may help us to definitely say yes, because she's only 42.
Yes,
So
ma'am.
we may say, yes, you are in transition period. One more thing, the clue we can get is we must ask her when her mother has attained menopause. If mother has had a early menopause, this definitely we can say, yes, you are also going for a perimenopausal or a transition period. Okay, how do we manage her? Perimenopausal, not she has not attained yet menopause, it's a perimenopause. How do you, but she has symptoms. So how
Yes,
will you manage her?
this our patient has vasomotor symptoms. There is no as such here. Counseling is must, ma'am. Counseling and lifestyle not modification. So we
Yes.
have both non-hormonal and hormonal management.
Mhm.
Here, this patient, because if she here she's bothered about her symptoms, so we have to concentrate on that. So
Okay.
we may have to, we will advise for hormonal therapy here for the vasomotor symptoms.
Okay.
And other management options here are depending on if it is only here she has mood disturbances. So other options are antidepressants and SSRIs, that is
Yes.
paroxetine and
Yeah.
sure.
SSRIs may help her because she is only mainly her symptoms are not vasomotor but
Sorry,
central
mood
nervous system.
yes, ma'am.
Mood problem. So SSRIs can help her, is it not?
Yes, ma'am.
So good, wonderful. So depending on the patient, it's not a same to everybody. Her symptoms, her age, what she wants, depending on that, we have to decide the treatment. There are many options. To choose the option, we have to decide what suits her best. Okay, that's what from your talk. Am I correct, Harshita?
Yes, ma'am.
Okay, thank you. Now, what is this? She says no hormones she doesn't want now. Okay. So we said that many things are there. First thing we say is no need of any specific therapy. You said counseling and lifestyle modification, they say first thing. Anybody for the matter, for any disease, we say first thing is counseling, second thing is lifestyle modification. Why we say lifestyle modification? You know that importance of it? I don't know whether I have time to go through. This is epigenetics is playing a big role in all our problems. What is epigenetics? It is nothing but our behavior, our food habits, our lifestyle. Any disease you call, from irritability to cancer, everything we are attributing to epigenetics now. So better we know about it. In that, the most important thing which modulates our problems in the body, cellular problems in the body, is this is not a DNA alteration, but DNA functional alteration occurs because of our lifestyle. So that is very, very important. So in this case also, first thing is we say lifestyle modification. What are the lifestyle modifications, Harshita, you want to advise her?
Ma'am, the first is diet, and
Yes.
then aerobic exercises.
Okay.
If at all there is a history of, I mean, to avoid caffeine,
Okay.
weight bearing, as it is there on the slide, fruits which are foods and fruits, vegetables, whole grains, lean protein, avoid alcohol, caffeine, limit caffeine, and even avoid tobacco, regular weight bearing exercises, avoid a second sedentary lifestyle, mindfulness, and that is yoga and meditation would improve her mood symptoms, and regular sleep hygiene, that is before going to bed, to avoid TV, mobile, computers. And the main important thing is to advocate on maintaining the ideal body weight
Wonderful.
for, yes, ideal BMI.
Yeah.
And supplements like calcium, vitamin D, and multivitamins will also help, ma'am.
They are used to heavy non-vegetarian diets and that and this. Probably we may have to tell them slightly to change. Wonderful. All the factors which have to be carried out. If suppose she is already on these things, yes, it is easy for her to follow. Maybe add an exercise and yoga and meditation definitely improves our immunity, and then become the stress level comes down. So epigenetics play a role here again, stress. So that may help a lot in bringing down severity of her symptoms. Okay. Now, what makes perimenopause worse? What are the conditions which will make it worse? Okay.
So, yes, ma'am. Eating saturated foods, a sedentary lifestyle, stress, smoking, alcohol, and even overeating. I mean, when you're not on a balanced diet, all this actually aggravates perimenopausal symptoms.
Yeah, this we have to tell to all our women. You know what? Once the women get a daughter-in-law in the family, you know what? They come and say, why should I work, madam? I have worked enough. No, now my daughter-in-law is there. Let her work. I'll sit and see TV. Please, we have to tell all of them, no, it is not. She has to work as far as possible. She must be working, no? Now, are there any health risks associated with perimenopause? Menopause, we know a lot of health risks are there. Okay. So, before I go to that, lady is in a perimenopausal period. You have told her you are in perimenopause. So, she stopped caring for contraception. Do you think she can conceive in a perimenopause period?
Yes.
Yes.
Yes, ma'am.
Yes, ma'am.
Because occasionally they ovulate. So, in a perimenopausal space, definitely we tell them to take contraception. If
Contraception.
not already sterilized or husband is vasectomized, any of those things, we have to give this counseling is very important, because I've seen, I delivered one lady at 50. I delivered more, 3, 4 of them at 40, 42, 45. So we have to tell them until they stop completely the period, they have got the chance to become pregnant. So they have to follow some sort of contraception. Now, what are the risks associated with this perimenopause transition? Not the menopause, the transition period. Is there any risk, or only when they become menopausal they have the risks? Yes, Harshita.
Ma'am, they do have risk even in the perimenopausal age group. That
Okay.
is, they are at a high risk for osteoporosis and fractures. So, checking of, I mean, DEXA, that is bone mineral density, is advised when
Okay.
patients start becoming symptomatic.
Okay.
And they do have even mental health issues, genitourinary. I mean, in the early, in the perimenopausal period, initially they start having osteoporosis, fracture, and fracture risk. And later in the menopausal, as they come near to menopause, then genitourinary issues. Initially itself, we have vasomotor symptoms, ma'am. Menstrual irregularities, vasomotor symptoms are seen in the early period, and then later you have genitourinary and osteoporosis and cardiovascular problems.
So this slide tells us that when a woman comes with the perimenopause, some symptoms like this, which is not normal for her, she's around that perimenopausal age group. Please take care of her because this can start very early. We may have to tell them to go to weight-bearing exercises and calcium and vitamin D intake here and be very active. And then probably genitourinary problems, as you said, can start little late. But these are the problems which can start even in perimenopausal period. So we may have to really counsel her properly for that. Is it not? Very nice.
Yes,
very
ma'am.
nicely brought up. Now, this is one. Now, Dr. Nagajyoti, 50-year-old Mrs. P she has a hysterectomy done for a fibroid uterus 3 months back. She had severe night sweats and frequent hot flushes. Her quality of life has become very bad because she is an executive. She works a lot, but now she is suffering with that. She has come to you saying that enough is enough, madam. Give me some solution. What is she suffering from?
She is
And
suffering
now-
vasomotor symptoms, madam.
Yes.
Menopausal vasomotor symptoms.
This is, she has got? Yes, ma. She has got a vasomotor symptoms. What are the vasomotor symptoms? How do you grade them? Nagajyoti garu.
Vasomotor symptoms are like patient gets a sort of heat wave followed by sweating, usually the upper part of the body, like head and neck, and followed by chills.
Okay.
Usually it is associated with palpitations,
Yes.
mild headache,
Yeah.
and if they occur in the night, they cause the sleep disturbances and they are called as night sweats.
Okay. Okay. So, this is it very common? Vasomotor symptoms, how common they are?
Madam, it is the hallmark of the menopause.
Okay.
Usually,
Now,
most of the
perimenopause.
patients.
Is it a hallmark of menopause alone or it can happen even in perimenopause?
It can happen in perimenopause also.
Okay.
Usually, it is seen in 80% of the patients.
Okay. So,
but not all of them have severe symptoms.
Okay.
They are manageable in most of the times.
Okay.
It is graded into 3 grades.
Okay.
Mild, moderate, and severe.
Okay.
Mild, there is a heat sensation without sweating.
Okay.
In moderate, there is a heat sensation with sweating, but it doesn't interfere with her daily activities.
Okay.
And severe is, it is interrupting her activities.
Okay. So that becomes a severe. Probably the quality of life will come down there, is it not? Okay. So probably we need to grade the symptoms. When they come with vasomotor symptoms, how many times in a day they get, how frequently, and mostly in the night, we must ask them how frequently they get it, because that disturbs their sleep and it is very, very annoying for them and very depressing also. So how many times she gets in the night with this, how frequent it is in the night, all these things will give us the severity of it. Okay, now she has got a very severe symptoms. This lady has come asking for the pen. Okay, this is how they grade it. This is the green climatic scale is there. In that all menopausal symptoms. In that 19 and 20 comes as a vasomotor symptoms. It is graded as not at all she has got, that is grade 0. Very little, 1 or 2 in a day probably. And then it is more than 3 or 4 comes the grade 2, and then very frequently, say like every 2 hours or 3 hours once she has. How much time it will last, Dr. Nagajyoti garu? How much time it will last if she gets the this one, vasomotor symptom each time?
It usually lasts for 2 to 5 minutes, madam.
Okay. So every 2 to 3 hours, if she is getting for 5 minutes, see how difficult it is. So that comes to the grade 3. So this 19 and 20, the entire thing is for the menopause. But in that, if we take vasomotor symptoms, depending upon the grade, probably we can say how severe it is. See, that is for the whole thing they have given it, but we can use this scale for using this also, green chromatic scale. Okay, fine. Now, although majority of women have VMS, but 20% of them may not have or may have very mild symptoms. What triggers this, Dr. Vinutana? What triggers these symptoms?
Yes, madam. The first and foremost thing is if she is a working woman under stress will be one of the factor.
Okay.
If she has got any addiction for smoking or alcohol, they are the triggering factors. And the thing is now, as we are experiencing very hot weather, that is summer, hot and very hot weather, that is one of the factor. And about food, spicy food and caffeine, more caffeine intake, these are all the triggering factors for vasomotor symptoms, madam.
Okay, so these are the common things, no? Spicy food we love. We go out every Sunday. We have to go to a hotel and eat all the spicy and red color food. And caffeine, of course, is our dearest one. So all these things probably is the things. Now, what are the other triggers? Any other trigger? They are the commonest triggers in life.
And most of the common medications, if they have any headache or body aches, if they go for frequent uses of NSAIDs, or any hypertensive if the woman were to be any on hypertensive medications, especially alpha blockers or beta blockers, ACE inhibitors, and if she has got any psychiatric issue or an antidepressants, those are also triggering factors for vasomotor
medication. We must tell her that these are the triggering factors for you to get this severe vasomotor symptoms. So ask your concerned doctors whether the dose can be reduced for some time so that this trigger will be lessened for her. Is it not?
Yes, madam.
Yeah, that's wonderful. Okay, now how should you manage her now? She has come, first person who has come with irritability, this, everything, vasomotor symptoms now.
So we have to ask.
Yes, how do you manage? Sweta is there?
Yes, madam. She has joined it.
Yeah, Sweta, can you answer this question? I didn't see her. Sweta, you're there?
Yes, madam. She's there.
Yeah, please, Sweta, can you go ahead with how do you manage her now? She has come with these symptoms. How would you like to manage her?
For the vasomotor symptoms, I would first request her to identify the triggers and advise her to avoid the triggers.
Very good. Wonderful.
I also feel sometimes tight clothing, tight blouse and all can also trigger it because it accumulates sweat and everything is again a vicious circle. I would also ask her to wear layers of clothing and stay in little comfortable temperature, not a very cold, because it can also act as trigger. So, and also I would ask her to reduce the spice levels in the food and decrease the amount of caffeine that is being taken in a day. I would, because suddenly if I say that just stop the caffeine, don't take coffee, it might be difficult. So I'll ask her to reduce it to 2 cups or 1 cup and slowly replace it with other options, ma'am.
Why don't they reduce I mean, see, that is a habit. Coffee is a habit for everyone, except me, of course. So you can't ask them to stop having coffee. No, that's a pleasure in the morning. But you can say they reduce the amount of coffee. And somebody is very, very, very addicted to strong coffee. So the caffeine is more in that. Probably that strength of it, she may bring it down, and the frequency she may bring it down. That's all. Twice a day should be okay for us, is it not? You can't ask them to change their entire lifestyle and become worse than what they are following. If everything she has to change, she'll be worse than having a vasomotor symptoms. Okay, that's it. Okay. Now, to keep the ideal BMI is important. Lifestyle modification and the diet habits, as you said correctly. Yes, these are the things we have to tell her before we start her and help her with any medication, is it not? Now, this is one thing which is coming up very prominently now. This is going to be a very promising thing, I think. Cognitive behavioral therapy. Okay, psychotherapists will give this. This is a form of psychotherapy. Can any one of you can speak about it? Yes, Sirisha? Yes, what is cognitive behavioral therapy?
It's a training of our brain, madam. It's a form of psychotherapy
Yes.
to reduce the symptoms of various mental health conditions, ma'am.
Yeah.
It's so that if you train your brain in a way that uh, to change our behavior, which should help in the decrease, which should help to decrease our problems like
Oh.
thought processing or any belief attitudes. So
Yeah.
that if we like what previously madam used to tell that decrease taking of caffeine, which is also comes under one of the cognitive behavioral therapy, so that we should control our brain to take less caffeine, for example, like that.
So I
So
think
you should
so. This
train the brain.
helps. Yeah, good, ma. This helps not only for this, for a whole thing in our life. Probably, if we are able to control our mind and then look at it in a positive way, things it helps a long way in our lives also. Probably this will help. And here they say that it has a promising results. Good, ma. Okay. Now comes here. 48-year-old attained menopause 2 years back, has severe vasomotor symptoms, tried all self-help measures with no relief. Her quality has become bad to worse now. Okay. Now she comes to you to offer something for her because all other things she has tried so far, whatever you spoke, she has tried again. So now she has come to you to give something else. Harshita, you have anything to offer to her extra than what all she says, all the tips, what you said, she has been following. But still, poor thing has suffered. You have something to offer to her?
Yes, ma'am. Ma'am, we can try non-hormonal therapy and hormonal therapy. Non-hormonal therapy,
It's a pharmacotherapy you want.
yes, yes,
So
yes,
just
ma'am.
before going into pharmacotherapy, can you tell some indications for pharmacotherapy, Harshita?
Severe, moderate to severe vasomotor symptoms, and here our patient has failed self-help remedies, and if the patient herself desires that she is not able to go into the self-help remedies and she requires pharmacotherapies,
Okay.
so that is another option.
Mhm.
And poor quality of life, that is disturbing her
It's a
daily
main
activities
option.
also.
Okay. So these are the some indications we can go for the pharmacotherapy. Okay. Yes. Next, who is the next? Nagajyoti garu. What are the drugs available for treating VMS in the pharmacotherapy? What do we have
Here
to offer to
again,
her?
we can divide them into hormonal and non-hormonal.
Okay.
Non-hormonal consists of the substances which increase the estrogen levels in the body, phytoestrogens, like
Okay.
they are found in soy products,
Yeah.
like flax seeds, red clover, and
Yeah.
lignans,
Yes.
and this Ayurvedic drugs like black cohosh,
Mm.
uh, and acupuncture also plays a promising role in all this.
Means acupuncture, yes. Acupuncture was really good, I believe. Okay. Yes.
And if she is not happy with non-hormonal therapy, then we can offer her hormones.
Phytoestrogens, Dr. Nagajyoti garu. What about phytoestrogens?
Phytoestrogens are the estrogen-like compounds that are produced from the
Plant-based.
plants, plant-based.
Are they helpful, do you think,
Uh,
for the
Actually,
vascular symptoms?
there are no so much of researches on the soy isoflavones, madam. Actually, as there are many researches on HRT, but that many they are not available for phytoestrogens.
Now they are doing, but only problem we have with phytoestrogens is I do give phytoestrogens and few people are very happy with that. But the problem is, see, it takes long time. They don't get a sudden relief like in the with the hormonal therapy, number one. Number two, the concern now is how much of the estrogen is there in this phytoestrogens, we don't know. That
Yes.
is not it has been, there are variety of phytoestrogens. In that, how much is the estrogen content, we don't know. Whether it is very less or it is sometime high. So that is not being able to research on that. So there's a little skeptical about giving the phytoestrogens for the patient. If estrogens are, the hormones are contraindicated, probably we can try phytoestrogens. Right, ma? Yeah, coming to the hormonal therapy. How effective is hormonal therapy and what hormonal therapies are available? Who will take this? Vinutana?
Okay, madam. Hormone therapy gives us the best result.
Phytoestrogen cited, it takes longer time and effect is not seen immediately. What about hormonal therapy? How effective it is?
It reduces the severity of hot flushes by almost 87%, and frequency of hot flush is also reduced by 78%. And hormone therapy is either estrogen alone or estrogen plus progesterone combination. Estrogen has to be offered to women who have undergone hysterectomy, and E plus P, that is estrogen and progesterone combination, for women with intact uterus. So there are various routes through which these can be administered, madam. And overall hormone therapy improves the quality of life and reduces the symptom severity.
But before giving hormone therapy, do you think any other precautions you have to take, and whom you will give hormonal therapy? Which are the patients who you choose to give hormone therapy? Suppose this lady has come to you, she is okay. What are the other concerns for you to start off hormone therapy?
The lady has to be under the age of 60 years. Yes. And menopause should be less than 10 years. That is, it should be less than 10 years from the age of menopause. From the onset of menopause. And women with especially comorbidities, either diabetes, obesity, uncontrolled diabetes, obesity, hypertension, like cerebrovascular, any kind of cerebrovascular disease. In those women, hormone therapy has to be used very cautiously.
With caution and then individualized counseling, then we have to give the hormone. Why the 60 years here?
Arteriosclerosis is...
Hello?
Madam, may I?
Most of the symptoms...
Madam, may I?
Yeah, I can hear you. Please go ahead. Vinithana? Hello?
Most of the symptoms in menopause or during the early menopause period, madam.
Okay, good. Late menopause, what symptoms we have? Yeah, especially hot flushes will be early. What is the span of hot flushes?
Cardiovascular.
What is the span of hot flushes we have? How many years they can have hot flushes if she starts?
Around 7 to 10 years.
1 to 2 years after.
That is usually frequency. Maximum how many years she can have?
5 years. First 5
1
years.
to 2 years,
First 5
madam.
years to 7. That's all. Yeah. After that, it may not have. That's why we say after 6, even if you want for the menopause also, we will come in the next sessions, we will be talking about menopause. Even there, hormonal therapy will not be started after 6 years, or if you have to be very, very choosy, and it is a shared decision it will be. Okay, we'll come to that later. Yeah, good, ma. This is all hormones, what is available. Estrogens in the market in India, what is available. One thing which is added is estetrol, because we want E1, E2, E3. We have studied about it when we were students and we know about all that. But there is E4 is added. That is estetrol. It seems to be very, very effective and very good. And all the complications of other estrogens are very minimum with the E4. So E4 has also come into the market, and this is also in the list of hormones which we can use. If it is only estrogen, as Vinithana said, these are all the things. Now what is used is usually 17-beta estradiol, conjugate equine estrogen, see that. Genitourinary symptoms, not for VMS, it is. That is vaginal cream. But conjugate equine estrogen, we have no Premarin cream was there, estrogen cream. That sometime it is available, sometime it is not. But that is only for it is very good for genitourinary, not for the VMS. Conjugate equine estrogen, instead of that, now they use 17-beta estradiol or estrone. Estrone injections nobody uses, but these are available. Coming to the progesterone alone, we never use, except in few rare cases where estrogen is absolutely contraindicated. We can use progesterone alone in the vasomotor symptoms, but it doesn't have as much as effect as estrogen. Now, tibolone is the other one which you can use it. It's a synthetic steroid. Tibolone can use orally 2.5 milligram every day. but it is not recommended for women who has got a breast cancer. And I've seen people having with the tibolone swelling of the legs, they get it. And it is not very safe for the endometrium also. So tibolone cannot be used when there is a family history of breast cancer or self having a breast cancer. We don't use tibolone. Otherwise, we can use even tibolone also. Okay, that's it. Now, how long MHT to be given and how soon the symptoms improve and how to follow up these women. Sirisha?
Yes, ma'am.
Yes, please.
Ma'am, duration of the MHT depends on the woman's symptoms, madam. The
Yes.
severity and frequency of the symptoms. And after receiving the MHT, the relieving of the symptoms also matters, madam.
Okay.
So based on all these conditions, we had to and monitoring of the patient based on the monitoring of the patient, compliance of the patient. All these factors comes into consider should be considered uh, to give MHT. I mean, how long to be given to the MHT to the woman mom.
Okay.
And how soon the symptoms improve means it again depends on the patient condition, mom. Sometimes it may relieve within 1 year or 6 months, 1 year or 2 years or 3 to 5 years, madam.
Yeah.
And how to follow these patients on MHT means initially you should follow for at least 3 months, madam. Later, annually we should follow, madam. And
Okay.
we should know the symptoms which are while using hormonal therapy. Some like irregular bleeding, or those might be within. Those are normal.
Yes.
So we should with it
Your voice is breaking.
normal, madam. If it is hello, madam.
Hello? Yeah.
Hello,
please.
madam. Yeah, ma'am.
Yes, we can hear you.
Yes, ma'am. So, based on the symptoms, like initial 6 months, some people who are using estrogen therapy may have irregular bleeding. So,
Yeah.
for that, we need not to evaluate. After that, also, she is having irregular bleeding, then we have to evaluate. And we have to monitor her symptom relief. So, all these, based on all these things, we can change the visit intervals, ma'am.
Okay. So probably if once you start, they get used to this and they may want to continue. Okay. So depending upon, as correctly said Surisha, you have to have a follow-up. If she has no other complications with this, she can continue because she has got a quality of life with this. So she can continue, provided she will come for a regular follow-up, is it not? So that is it. And suddenly we should not stop. We must tell them that, yeah, I'm okay, madam. Now I have taken 6 months. I want to stop it. Please tell her not to stop it suddenly, but she has to taper off. Say once in 2 days, you can take every day she was taking, now once in 2 days, then make it twice in a week, then once in a week, then stop it so that she will not have a rebound symptoms again. That is what, because suddenly you take off estrogen, again, rebound symptoms is a possibility. So we have to tell her slowly, the body must get used to that low dose of estrogen, and then it can be withdrawn completely. Wonderful. That's good. So can take lifelong. She wants to take because she feels very good. Sweta, she's feeling very good with this. Can she take for lifelong? She's asking you, madam, why can't I take?
Ma'am,
What's your answer to that question?
There is a limit for the treatment, ma'am. We can continue it up to 60 to 65 years because patient will definitely feel very good after starting the MHT within a month or two. So as we keep following her up, once we feel that she is doing okay, like we can tap her the dose and tell her that this can't be used forever because and we need to keep a limit of at least 60 to 65 years.
Good. Up to 60 to 65 years, you can say, but provided you take certain risks, we have to tell her. It is called shared decision. So she has to decide for herself in spite of us telling her every possible problems with this for prolonging it for a long. One concern for prolonging it for a long time, that is more than 10 years is, what is the main concern for us more than 10 years if we continue the hormone therapy? Breast cancer. Increased risk of breast cancer is the concern for us. So we have to explain that to her And if she still continues, wants to take it up, it's her decision. Okay, that's it. Now, are there contraindications for MHT, and what are the absolute and relative contraindications? Harshita? Harshita, you are there?
Ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. We have absolute contraindications whenever there is undiagnosed vaginal bleeding, or when there is family history or past history of breast cancer or endometrial cancer, acute cardiovascular events, family history, and I mean, we have to think over when there is even past history of acute venous thromboembolism, severe liver disease, and porphyria tarda. So these are absolute contraindications.
If you have family history, Harshita,
Yes, ma'am.
you have to say it's an absolute contraindication.
Contraindication.
Bleeding?
Ma'am, she is at a higher risk, so she should
If
be.
she had a cancer, if she had a hormone dependent cancer, if she has a ER/PR positive breast
Positive.
cancer,
Yes, ma'am.
she had
Then
endometrial cancer, which is again dependent on the hormone. You have to be very, very cautious giving her the hormone therapy, is it not? But if she has a family history, probably we can tell her the risk, a little higher risk you have compared to the general population. But I think we can give her if she is needing it, is it not?
yes, ma'am.
Yes,
Okay.
ma'am. Go ahead. The relative contraindications are?
Post myocardial infarction and transient ischemic attacks or stroke, and when there is high risk of venous thromboembolism, active liver disease, migraine, hypertriglyceridemia, and high risk of breast cancer is there, and when the age is older than 65 years, and when there is also no prior history or usage of hormonal replacement therapy, then these are all relative contraindications.
This is beautifully given. NB is exercise caution with oral. All this comes under B3 category. They are better off if you give the transdermal estrogen rather than the oral estrogen. Because here in these cases, that's what I said, even a breast cancer patient, or she's a high risk for breast cancer, triglyceridemia, all the migraine is, we used to say contraindication, liver disease is a contraindication, we used to say. But now they say all these people can be given, but they have to give transdermal rather than oral. Oral is more prone for all these problems. So you can give a transdermal. Only place where you have to be, it is say that contraindication is transient ischemic attack and stroke. This is the place where probably you may have to say you have to be very cautious, or you go for a other therapy rather than hormonal therapy. What are the other drugs can be? Suppose she had a stroke, so she cannot take, but she has a vasomotor symptoms, poor thing, with a residual paresis she has got. Now, how can you help her out? Yes, Naga Jyoti.
Yes, madam. There
How
are
can you help
other
her out?
non-hormonal drugs.
She says, I don't want because I had a stroke also. Can you help her out with something else, ma'am?
Yes, madam.
Yeah.
We have non-hormonal drugs. There are SSRIs and SNRIs.
Yes.
And these days, this paroxetine, which is being used commonly.
Okay.
And the other drugs are gabapentin.
Yeah.
Clonidine.
Yeah.
And we have heard only those, madam. Here the slide shows oxybutynin and neurokinin B.
Neurokinin B antagonist seems to be promising. Fezolinetant. They said that this is really working well because it works at what is the exact pathophysiology of vasomotor symptoms. I'm not going into the details of it. There it works and it prevents the vasomotor symptoms, I believe. Neurokinin B antagonist. Okay, it is called either NTA-Y814 or it is fezolinetant. This is available. Okay. Now this is other selective estrogen. Tissue selective estrogen complexes are coming up now. They are also very good, I believe. Now it is on the trial now. Phase 3 trial is going on for the selective estrogen complexes, tissue selective estrogen complexes. So each tissue, it has got efficiency. There is a beneficial effect. Along with that, benzodoxepin is combination of the estrogen and benzodoxepin. Those work very well for hot flushes. Along with that, they have got a protective effect for the endometrium and breast, and they have an effect on the bones also, bone medulla. So these are the ones which is coming up now, tissue selective estrogen complexes. Wonderful. That's it. Now there are small situations where it is everything in life is not a straight line, no? We have always curved lines also. There are few situations will come to us. Now 50-year-old lady with a BMI of 32. She has got a heart flushes. She wants to take MHT. What's your take on that? Any one of you, please. You choose yourselves and talk. What is your take on this? She wants to take. What do you say? How do you counsel her? What will you say to her? Can she take
Because,
or not?
her BMI is 32. She
Yes.
comes under grade 2 obesity.
Yes.
Yes, we ask her first to avoid the triggers and to lose the weight.
Wonderful.
All the lifestyle modifications, dietary changes, all this, because it is shown that the loss of 5% of the body weight decreases the hot flashes significantly.
Wonderful. Okay.
And if at all she is very particular and this is a shared decision, so that we will go for hormone therapy. Because of the obesity and other risk factors, it is better to go for transdermal route of
Yeah,
estrogens.
she comes into NB3 classification. Previous slide we have seen. So, but a wonderful ma. She goes into transdermal patch. She can go. Plus, because she has got a uterus, she has got a transdermal patch for the estrogen. I mean, in our country, we don't have a patch which has both estrogen and progestogen. Estrogen patch with the progesterone supplementation we may have to give her. Is it not? Yes, wonderful. Now, next is 48-year-old lady. She had endometrial CA and she had a total hysterectomy with bilateral salpingo-oophorectomy. 1 year back, she now comes with severe vasomotor symptoms. Yes, who will take this? Yes, one of you. How do you solve her problem, please? Yes, Sweta.
Madam, we have to, as we shared decision should be taken, we need to inform her that she hormone therapy is not can be taken, and it should be a combined therapy. We have to individualize the decision, ma'am. So, and also alternative therapies also should be offered, ma'am.
Yes, very good. Alternative therapies first we have to offer her. If she is not getting any relief, you guys 48 years and hysterectomy, no. Suddenly, if you take off the ovaries, she'll have. Plus, she has the tension of having a cancer uterus. So we have to give some relief to her. See, with this, she may go for the central nervous system and this one psychotic problems also, irritability, depression, all that she is going for. So to avoid all those things, probably we can go. But please remember, first 2 years, she's only 1 year since operated. So next 1 year, we cannot give hormone therapy for her. Minimum interval should be 2 years. So in that 1 year, we have listed so many drugs we have spoken about, non-hormonal, that can be given to her. And if she is not getting any relief with that, probably we can go for hormonal therapy, that too transdermal, not oral, with a very, very cautious. And here one more thing is you have to give combined. You can't give estrogen, though uterus is not there. We have to give combined therapy because anywhere it can come. And one more thing we have to remember, if it is endometrial carcinoma, we can give. But if it is anything else, clear cell carcinoma, definitely we cannot give because it's a very, very virulent cancer. So that is also, we have to think of histopathology of the cancer. What is it? If it is only endometrial, yes, probably we can give her. Now, 50-year-old being diabetic for 15 years, menopausal transition with a severe VMS. Can we be able to help her? Severe VMS, this is severe. So can we be able to help her?
Yes, ma'am.
Yes. Who will take, Sirisha?
Yes, ma'am.
Yes.
Yes, madam. In this estrogen in MHT has a favorable effect on glucose metabolism because she is a diabetic for past 15 years. So we can provide her MHT, but along with that, we should counsel her regarding the risk, the complications of MHT being a 15 years of menopausal and diabetic, there is a chance of more atherosclerosis on her.
Menopausal transition. She is not at menopause.
Okay.
She's menopausal transition. Okay.
So we can give her a hormonal therapy safely, madam. It will help her as she is diabetic. It will help her insulin mechanism since increases insulin.
See, as against our thinking
Yes.
that diabetes is a contraindication, probably hormone therapy facilitates and it brings down the blood glucose level and it reduces the insulin resistance and increases the insulin sensitivity in the body, I believe. But only thing is, if suppose she is added obesity, usually it happens in the diabetics, then will be a problem. Then we have to go only for transdermal. If she is not obese and she is only the diabetic, probably with a caution, we can give her oral and hormonal therapy. We have to give both estrogen and progesterone. Is it? But only problem is addition of progesterone will blunt the effect of estrogen. That we have to think of. So her glucose level may be little fluctuating. So we have to tell her to keep a control of blood sugars, tight control of blood sugars. Okay. She has 45-year-old had hysterectomy and ovarian removal for endometriosis. Now she has got a vasomotor symptoms. What can we do for? Can we help her in any way? Any one of you, please. Any one of you can take it up. Yes?
Yes, ma'am.
How do we help her? She's endometriosis.
Yeah, yes, ma'am.
Yes, please.
Because here we can give. She's having the endometriosis. Maybe we can give non-hormonal methods, madam.
Yes. Because suppose she doesn't get relief with a non-hormonal.
We can give even hormonal therapy also, madam. But there is a chance of recurrence of endometriosis. We should counsel her, and we should treat the endometriosis complications.
Yeah.
Also,
we should caution the decision again. We have to tell her you may get so non-hormonal. Lot of things are there. She can try all those things, including CBT. Is it not? Counseling, everything she can try. But if she is not getting relief and she is bending on to take the hormone therapy because somebody has told her and she also read a lot about the benefits of hormone therapy over the menopause and then the osteoporosis and all, we have to give her the caution that endometriosis can recur. So we have to add progesterone also along with estrogen. Like in endometrial cancer, we have to add progesterone, not estrogen alone. Same like that in endometriosis also. Even though uterus is not there, she has got the uterus removed, but still we need to add the progesterone along with the estrogen. These are the small things which we have to remember so that we do less harm to the patients and more benefit to them by all these things. Okay. So overview of the VMS. VMS is a common during menopause transition and during menopause also. It may last up to 7 to 8 years and somebody can have lifelong. My mother-in-law had at 80s, I would see her with the hot flushes. She used to be with me. So I used to see her at 80s. Even hot flushes she used to have, but very occasionally in the day 1 or 2 she used to have. Severity differs in each individual woman. That depends again how well we are mentally, how strong we are. It depends on that mainly and our lifestyle and epigenetics. As I told you, one new word I brought in. It's not new. Now everywhere it's epigenetics. Lifestyle modification, avoiding the triggers is the first line therapy for the mild cases. Please don't put them on straight away. We can put them on straight away hormones if they don't have any contraindications because that will help even at the menopause, when they reach menopause. But if they have some complications or some high risk factors for the hormone therapy, maybe we can start trying with non-hormonal, avoiding the triggers, then non-hormonal therapy, then come to MHT. MHT is the most single effective therapy for VMS, no doubt about it. Proper selection of women is crucial. That is most important for us. Duration of therapy is again, all of you said it is individualized. Somebody wants to take lifelong also. We said, Sweta said up to 65 years, yes, I have no problem, madam, I'll give to them. She said, fine. Non-hormonal therapy where MHT is contraindicated is still valuable. Cognitive behavioral therapy has come in a big way and it has got very promising results. That's about VMS. I thank the organizers once again, and I thank all the panelists for doing a wonderful job for me and making my life very easy. And I thank, if there are any audience, I thank them for their patient listening. Thank you all of. Thanks a lot.
Thank you, madam.
Thank you, ma'am.
Dr. Rajni Bal.
Is any questions we can answer?
Madam, in
Yes.
the previous slide, we have one question among that diabetes mellitus lady. In some people, diabetes mellitus, there is some chance of atherosclerosis is there, no, ma'am.
Yeah.
So in those diabetic patients, is estrogen therapy is more
atherosclerosis, if there is there, you don't measure there is a way how to measure atherosclerosis now. If they have cardiac symptoms, okay,
yeah.
You go for transdermal and the lowest dose.
Okay.
If they have a cardiac symptoms because of atherosclerosis, see, every one of us have atherosclerosis. As we age, certain amount of a narrowing of the vessels will be there, is it not? Atheroma formation. It is but natural. But if because of that, if they have a cardiac symptoms, like we saw hypertension, stroke, or if they have any of those things, then you have to be very cautious. If it's only pure diabetes, she doesn't have any other cardiac lesion or she doesn't have hypertension, then probably we can go for oral therapy.
Ma'am,
Okay.
I want to know that how transdermal patch can be used, like the duration of treatment.
There are patches, dose will be there. The manufacturers will tell us how many days one patch has to be replaced. See, we used to have estrogen patches. I used to use it. We put it on the anterior surface of the thigh, not near to the heart. So on the arms, we don't put. We ask them to put it on the anterior surface of the thigh. Okay, once in a week. It used to be, it was very comfortable for us. We used it for quite some time. Suddenly it vanished from the market. So we used to use it. Once in a week, they change the patch.
Thank you.
Any questions in the chat box? Hello?
I
Yeah,
feel
ma?
like while we
Hello? Yes?
Is it available in India, madam?
Now it's available. Patches are available now. Now it has come, combined patches are there now.
Okay.
Estrogen and
Can
progestogen
we know the
combined
brand
patches
name
are
of
also
that?
there.
Can we know the name of the patch? Like, how do you prescribe? Like, I understood that it is dose dependent, but what is the name of the patch you regularly use, ma'am?
I mean, I don't know now because a lot of companies have come up. You can search in the thing. It is there. Estrogen patch, we used to call it as estrogen. One or two companies only do it. Probably we'll get it.
Sure.
But I'm not very sure whether we have a combined patch in India.
Okay.
Abroad, it's available very much. Estrogen patches antana ide, not the technical, I mean, the generic name we know, but the company names I don't know because different companies make different.
Yes,
Ma'am?
Yes, please.
Ma'am, a small question. Nowadays, we are seeing many patients with surgical menopause.
Yes.
So, to prevent them developing vasomotor symptoms, because early, can we start them on MHT? What is the role of MHT as on preventive aspect, ma'am? I mean, there are certain gynecologists who are starting tibolone soon after hysterectomy too.
Yeah, because see, if you do hysterectomy without ovarian removal of the ovaries, you don't need to start anything. If you,
Yes,
for some
ma'am.
reason, you have removed the, say, up to 60 normal ovaries, we don't remove now here.
Yes, ma'am.
If you are, she needs a hysterectomy, because she needs hysterectomy, we don't do oophorectomy now, up to 60. The patch which is available is Estradiol, which is available in India, Estradiol. The name of the patch, okay? Yeah.
Noted.
If you remove the ovaries, there is no problem. You don't need to start. Once you remove the ovary, definitely you have to start because there is no estrogen in the body.
Yes, ma'am.
And not only the vasomotor symptoms, they are going to have a lot of other problems. Main thing is osteoporosis. Is it not? So to prevent that, you can start MHT.
Like at the time of discharge only can we start off, ma'am? Or when should we?
At the time of discharge, you don't start because of wound healing and all. You need to know. You need to know the histopathology of the specimen. What you have. There should not be any hyperplasia of the endometrium. All that.
3 months.
Then as soon as 1 month time, you can start off.
Okay.
Even before they get any. Suppose she said say 48, 49 years. Yes, you can start off within 2 weeks once the wound heals well. You can start. There is no correlation between wound healing and starting estrogen. You can start off even when she is in the hospital. You can start if they are young.
Okay, ma'am.
Once you remove the normal functioning ovaries.
Ovaries.
You have done for a post-menopausal woman hysterectomy. Her ovarian function is already not there. If she comes with any symptoms, probably you can start.
Okay.
Okay?
Yes, ma'am. Thank you.
Madam,
Yes, please.
it is said that the ovarian function ceases after the removal of uterus, like 1 to 2 years after the surgery. Then what is in what way we want to conserve her ovaries, madam?
See, because you do hysterectomy, what happens is early ovarian function ceases because when you are clamping the vehicles, the partially ovary is supplied by both the arteries, ovarian artery and the uterine. There's a branch there in the infundibulopelvic ligament. You have this both supply. So you cut off the supply. So ovaries may not have that much of vascularity, so that it will be 1 to 2 years earlier than when you preserve the ovaries. Okay. That's why your ovarian function will cease within 1 to 2 years of hysterectomy, they say. Okay. If it is ceases hysterectomy, after hysterectomy, she comes with the menopausal symptoms. When she comes with the menopausal symptoms, you start on MHT. Is it that you wanted, Dr. Nanjyoti?
No, madam. Here, when the question was asked, like at the time of
Why don't
discharge.
you remove the ovaries? Why don't you remove the ovaries? That is your question.
Yes, madam.
2 years she will have the benefit. No. After that also, I tell you, ovaries produce testosterone. That testosterone will get converted into estrogen in the periphery. Women are little obese.
Yes.
So once the ovaries stop producing estrogen, because your follicles are not there, from the stroma of the ovary, testosterone is produced, that is converted into estrogen. That estrogen is enough to keep you going on. That's why up to 60 years, please don't remove the ovaries if the ovaries are not pathological, number 1. Number 2, you have to tell the patients, if we keep the ovaries, sometime we have seen ovarian cyst will happen in them. And one more potential, this one you are leaving it for the ovarian cancer. That doesn't mean that every woman looking normal ovaries removed at 40, 45, 50. No way. They can sue us in the court of law if we remove the ovaries at that age. So we should not remove the ovaries now. Okay. I think that's an answer you wanted to know. Why
Yes,
can't
madam.
you remove 2 years? There is no guarantee that each woman at the dot of 2 year in the calendar, ovarian function will stop. No way.
Okay. Yes.
Okay. Some hormone is produced in the ovary. Okay. Okay. Any other question? I don't know whether there are audience, only we are there.
No, madam, they are there, madam. Only 5 members are the panel members. Rest of the 20 members are the audience, madam.
Oh, they have another link, is it? The audience have got a different link, is it?
No, madam,
No,
link
madam.
is same.
Here we can see, madam, participants.
We don't know how many people are there. Okay, 22 people.
25 members are there, madam.
Now,
Okay.
few have left, madam.
Okay.
But during the session, almost 25 members have attended the session.
Okay. That's it.
Madam, can we
Close the session? Yes.
Yes, madam.
The organizers, if there are no other questions in the chat box, there are no questions, no, in the chat box.
Madam Rajini
No,
Bala,
madam.
madam. Thanks.
Yes, madam, we can close the session now. There are no questions in the chat box. Dr. Rajni Bala, madam, who is our president for Menopause Committee in Anantapur, which we need to plan with your advice. She'll be giving vote of thanks to this to you and the company which has organized, madam. Rajni Bala, madam.
మేడం అన్మ్యూట్ చేసుకోండి మేడం. మేడం రజనీ బాలా మేడం అన్మ్యూట్ చేయండి మేడం.
Now?
Yes, madam.
Yes,
you are
madam.
audible.
Yes, madam.
Yeah. So definitely I would have very, very wonderful evening this day. So good evening, everyone. It is my great honor and privilege to deliver the vote of thanks on this occasion. First and foremost, I would like to thank our chief guest, Dr. Sundari Madam Garu, and the Krishna Sasi sir also for taking the time out of their busy schedule to grace this event with their presence and their knowledgeable words or knowledgeable lectures. And a big thanks to speakers and panelists for sharing their knowledge and experience and making this event lively and enriching. Special thanks to all my senior and junior doctors who are joining us today and making this event truly memorable. Once again, thank you all. Let us carry forward the spirit of this event and look ahead to many more such occasions. Thank you and have a wonderful day. Madam Sundari, Madam, very, very big thanks to you.
Thank you. Thank you.